بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. إن شاء الله رب العالمين هنتكلم النهاردة عن اليورينري بلادر كانسرز. هنتكلم بالتفصيل عن اليورينري بلادر كانسرز. أي حاجة تحب تعرفها عن اليورينري بلادر كانسر إن شاء الله هتكون موجودة في المحاضرة. هتلاقي الكلينيكال بيكتشرز، الكوزز، التايبس، هتلاقي الانفستيجيشنز، هتلاقي الجريدنج والستيجنج، هتلاقي السيرجيكال تريتمنت، هتلاقي الكيموثيرابي والراديوثيرابي، هتلاقي البروجنوزس. كل ما يتعلق باليورينري بلادر كانسرز إن شاء الله رب العالمين هتلاقيه موجود في المحاضرة دي. نتمنى إن شاء الله رب العالمين إنها تعجبكم وتفيدكم.
What is bladder cancer? Bladder cancer is an uncontrolled abnormal growth and multiplication of cells in the urinary bladder, which have broken free from the normal mechanisms that keep uncontrolled cell growth in check. Bladder cancer, like cancers of other organs, has the ability to spread metastasize to other body parts, including the lungs, bones, and liver. Bladder cancer invariably starts from the innermost layer of the bladder, for example, the mucosa, and may invade into the deeper layers as it grows. Alternately, it may remain confined to the mucosa for a prolonged period of time. Visually, it may appear in various forms. Most common is a shrub-like appearance, papillary. But it may also appear as a nodule, an irregular solid growth, or a flat, barely perceptible thickening of the inner bladder wall.
What are the types of bladder cancer? 1. Urothelial carcinoma, previously known as transitional cell carcinoma, is the most common type and comprises 90 to 95% of all bladder cancers. This type of cancer has two subtypes. 1. Papillary carcinoma, growing finger-like projections into the bladder lumen. 2. Flat carcinomas that do not produce finger-like projections. Urothelial carcinoma, transitional cell carcinoma, is strongly associated with cigarette smoking. 2. Adenocarcinoma of the bladder comprises about 1 to 2% of all bladder cancers and is associated with prolonged inflammation and irritation. Most adenocarcinomas of the bladder are invasive. 3. Squamous cell carcinoma comprises 1 to 2% of bladder cancers and is also associated with prolonged infection, inflammation, and irritation, such as that associated with long-standing stones in the bladder. In certain parts of the Middle East and Africa, for example, Egypt, this is the predominant form of bladder cancer and is associated with chronic infection caused by schistosoma worm. 5 other rare forms of bladder cancer include small cell cancer in bladder nerves, pheochromocytoma rare, and sarcoma in muscle tissue. What are bladder cancer causes and risk factors? 1. Cigarette smoking. About 50% of all bladder cancers may be caused by cigarette smoking. The longer and heavier the exposure, greater are the chances of developing bladder cancer. The toxic chemicals in cigarette smoke, many of which are known cancer-causing substances, carcinogens, travel in the bloodstream after being absorbed from the lungs and get filtered into the urine by the kidneys. They then come in contact with the cells in the inner lining of the urinary system, including the bladder, and cause changes within these cells that make them more prone to developing into cancer cells. Quitting smoking decreases the risk of developing bladder cancer but takes many years to reach the level of people who have never smoked. However, as time passes after the quit date, the risk progressively decreases. In view of the above, it is extremely important for patients with bladder cancer to stop smoking completely, since the chances of the cancer coming back after treatment are higher in those people who continue to smoke. People who smoke also have a higher risk of many other types of cancer, including leukemia and cancers of the lung, lip, mouth, larynx, esophagus, stomach, and pancreas. Smokers also have a higher risk of diseases like heart attacks, peripheral vascular disease, diabetes, stroke, bone loss, osteoporosis, emphysema, and bronchitis. 2. Age and family history are other risk factors, as is male sex. About 90% of people with bladder cancer are over age 55, though in exceptional cases the disease may surface in the 3rd or 4th decade of life. Men are more prone to developing bladder cancer, probably due to a higher incidence of smoking and exposure to toxic chemicals. A close relative with a history of bladder cancer may increase the predisposition for the development of this disease. 3. Exposure to toxic chemicals such as arsenic, phenols, aniline dyes, and acrylamines increase the risk of bladder cancer. Dye workers, rubber workers, aluminum workers, leather workers, truck drivers, and pesticide applicators are at the highest risk. 4. The drug pioglitazone actose used to treat type 2 diabetes has been suspected to increase a person's risk to develop bladder cancer. 5 radiation therapy such as that for prostate or cervical cancer, and chemotherapy with cyclophosphamide cytoxin has been shown to increase the risk for development of bladder cancer. Moreover, it may also delay the diagnosis of bladder cancer in patients presenting with symptoms of bleeding in urine, since this bleeding may be incorrectly attributed by the patient or the physician to the bladder irritation caused by the chemotherapy or radiation cystitis. 6. Long-term chronic infections of the bladder, irritation due to stones or foreign bodies, and infections with the blood fluke prevalent in certain regions of the world as mentioned earlier are some other factors which predispose to bladder cancer. Signs and symptoms of bladder cancer. 1. Hematuria, blood in the urine. In most cases, blood in the urine is the first warning sign of bladder cancer. Sometimes, there is enough blood to change the color of the urine. Depending on the amount of blood, the urine may be orange, pink, or, less often, darker red. Sometimes, the color of the urine is normal but small amounts of blood are found when a urinalysis is done because of other symptoms or as part of a general medical checkup. Blood may be present one day and absent the next, with the urine remaining clear for weeks or months. If a person has bladder cancer, blood eventually reappears. Usually, the early stages of bladder cancer cause bleeding but little or no pain or other symptoms. Blood in the urine does not always mean you have bladder cancer. More often it is caused by other things like an infection, benign non-cancerous tumors, stones in the kidney or bladder, or other benign kidney diseases. But it is important to have it checked by a doctor so the cause can be found. 2. Changes in bladder habits or symptoms of irritation. Bladder cancer can sometimes cause changes in urination, such as 1. Having to urinate more often than usual. 2. Pain or burning during urination. 3. Feeling as if you need to go right away, even when the bladder is not full. These symptoms are also more likely to be caused by a benign condition such as infection, bladder stones, an overactive bladder, or an enlarged prostate in men. Still, it is important to have them checked by a doctor so that the cause can be found and treated, if needed. 3. Symptoms of advanced bladder cancer. Bladder cancers that have grown large enough or have spread to other parts of the body can sometimes cause other symptoms, such as 1. Being unable to urinate. 2. Lower back pain on one side. 3. Loss of appetite and weight loss. 4. Swelling in the feet. 5. Bone pain. How is bladder cancer diagnosed? Bladder cancer is often found because of signs or symptoms the person is having, or it might be found because of lab tests the person is getting for another reason. If bladder cancer is suspected, exams and tests will be needed to confirm the diagnosis. If cancer is found, further tests will be done to help determine the extent stage of the cancer. 1. Medical history and physical exam. A physical exam provides other information about possible signs of bladder cancer and other health problems. The doctor might examine the rectum and vagina in women to feel for a bladder tumor, determine its size, and to see if and how far it has spread. If the results of the exam are abnormal, doctor will probably do lab tests such as a urinalysis and might refer to a urologist for further tests and treatment. 2. Cystoscopy. If bladder cancer is suspected, doctors will recommend the cystoscopy. For this exam, a urologist places the cystoscope, a slender tube with a light and a lens or a small video camera on the end, through the opening of the ureter and advances it into the bladder. Sterile salt water is then injected through the scope to expand the bladder and allow the doctor to look at the inner lining of the bladder. If an abnormal area or a growth is seen, it will be biopsied. A thin instrument will be threaded through the cystoscope to remove a small piece of tissue, which is then sent to a lab and looked at under the microscope. Salt water washings of the inside the bladder may also be collected to look for cancer cells. Fluorescence cystoscopy may be done along with routine cystoscopy. For this exam, drugs called porphyrins are put into the bladder during cystoscopy. They are taken up by cancer cells. When the doctor then shines a blue light through the cystoscope, any cells containing the porphyrins will glow fluoresce. This can help the doctor see areas with cancer cells that might have been missed by the white light normally used. 3. Lab tests. 1. Urine cytology. For this test, the sample of urine is looked at under a microscope to see if it contains any cancer or precancer cells. Cytology is also done on any bladder washings taken when the cystoscopy was done. Cytology can help find some cancers, but this test is not perfect. Not finding cancer on this test doesn't always mean you are cancer-free. 2 urine tumor marker tests. Different urine tests look for specific substances released by bladder cancer cells. These tests may be used along with urine cytology to help determine if a person has bladder cancer. They include the tests for NMP22 and BTA, the immunocyte test, and the urofycin test. Some doctors find these urine tests useful in looking for bladder cancers, but they may not help in all cases. Most doctors feel that cystoscopy is still the best way to find bladder cancer. Some of these tests are more helpful when looking for possible recurrence of bladder cancer in someone who has already had it, rather than finding it in the first place. 3. Biopsy. A biopsy is the removal of a small sample of body tissue to see if it is cancer. The tissue that is removed is sent to the lab, where it is looked at by a pathologist. If bladder cancer is suspected, a biopsy is needed to confirm the diagnosis. M.B. Bladder biopsies. Bladder biopsy samples are most often obtained during cystoscopy. The biopsy can show whether cancer is present and what type of bladder cancer it is. If bladder cancer is found, 2 important features are its invasiveness and grade. 1. Invasiveness. The biopsy can show how deeply the cancer has grown into the bladder wall, which is very important in deciding treatment. A. If the cancer stays in the inner layer of cells without growing into the deeper layers, it is called non-invasive. B. If the cancer grows into the deeper layers of the bladder, it is called invasive. Invasive cancers are more likely to spread and are harder to treat. C. You may also see a bladder cancer described as superficial or non-muscle invasive. These terms include both non-invasive tumors as well as any invasive tumors that have not grown into the main muscle layer of the bladder. 2. Grade. Bladder cancers are also assigned a grade, based on how they look under the microscope. A low-grade cancers look more like normal bladder tissue. They are also called well-differentiated cancers. Patients with these cancers usually have a good prognosis. The high-grade cancers look less like normal tissue. These cancers may also be called poorly differentiated or undifferentiated. High-grade cancers are more likely to grow into the bladder wall and to spread outside the bladder. These cancers can be harder to treat. People with bladder cancer may develop more cancers in other areas of the bladder or in the urinary system. For this reason, during the biopsy the doctor may take tissue samples from several different areas of the bladder lining. Biopsies to look for cancer spread. If imaging tests suggest a cancer might have spread outside of the bladder, a biopsy is the only way to be sure. In some cases, biopsy samples of suspicious areas are obtained during surgery to remove the bladder cancer. M.B. Needle biopsy. Another way to get a biopsy sample is to use a thin, hollow needle to take a small piece of tissue from the abnormal area. This is known as a needle biopsy, and by using it the doctor can't take samples without an operation. Needle biopsies are sometimes done using a CT scan or ultrasound to help guide the biopsy needle into the abnormal area. For imaging tests. Imaging tests use X-rays, magnetic fields, sound waves, or radioactive substances to create pictures of the inside of the body. If bladder cancer, doctor may order some of these tests to see if the cancer has spread to tissues near the bladder, nearby lymph nodes, or to distant organs. If an imaging test shows enlarged lymph nodes or other possible signs of cancer spread, some type of biopsy might be needed to confirm the findings. 1. Intravenous pyelogram. An intravenous pyelogram (IVP), also called an intravenous urogram (IVU), is an X-ray of the urinary system taken after injecting a special dye into a vein. This dye is removed from the bloodstream by the kidneys and then passes into the ureters and bladder. The dye outlines these organs on X-rays and helps show urinary tract tumors. 2. Retrograde pyelogram. For this test, a catheter is placed through the ureter and up into the bladder or into a ureter. Then a dye is injected through the catheter to make a lining of the bladder, ureters, and kidneys easier to see on X-rays. This test isn't used as often as IVP, but it may be done along with ultrasound of the kidneys to look for tumors in the urinary tract in people who can't have an IVP because they are allergic to X-ray dyes. 3. Computed tomography CT scan. A CT scan of the kidney, ureters, and bladder is known as a CT urogram. It can provide detailed information about the size, shape, and position of any tumors in the urinary tract, including the bladder. It may be used instead of NIVP to look at the upper part of the urinary system. It can also help show enlarged lymph nodes that might contain cancer, as well as other organs in the abdomen and pelvis. Instead of taking one picture, like a standard X-ray, a CT scanner takes many pictures as it rotates around you. The computer then combines these pictures into an image of a slice of your body. Cord-guided needle biopsy. CT scans can also be used to guide a biopsy needle into a suspected tumor. This is not used to biopsy tumors within the bladder, but it can be used to take tissue samples from areas where the cancer may have spread. For magnetic resonance imaging MRI scan. Like CT scans, MRI scans provide detailed images of soft tissues in the body. But MRI scans use radio waves and strong magnets instead of X-rays. The energy from the radio waves is absorbed and then released in a pattern formed by the type of body tissue and by certain diseases. The computer translates the pattern into very detailed images of parts of the body. A contrast material called gadolinium is often injected into a vein before the scan to see details more clearly. MRI images are particularly useful in finding signs that the cancer has spread outside of the bladder into nearby tissues or lymph nodes. A special MRI of the kidneys, ureters, and bladder, known as an MRI urogram, can be used instead of NIVP to look at the upper part of the urinary system. 5. Ultrasound. Ultrasonography uses sound waves to create pictures of internal organs. It can be useful in determining the size of a bladder cancer and whether it has spread beyond the bladder to nearby organs or tissues. It can also be used to look at the kidneys. This is an easy test to have. It uses no radiation, which is why it is often used to look at developing fetuses. Ultrasound-guided needle biopsy. Ultrasound can also be used to guide a biopsy needle into a suspected area of cancer spread in the abdomen or pelvis. 6. Chest X-ray. A chest X-ray may be done to look for spread of bladder cancer to the lungs. This test is not needed if a CT scan of the chest has been done. 7. Bone scan. A bone scan can help look for cancer that has spread to bones. Doctors don't usually order this test unless patients have symptoms such as bone pain, or if blood tests show the cancer might have spread to your bones. How is bladder cancer staged? The stage of a bladder cancer is a standard summary of how far the cancer has spread. It is one of the most important factors in choosing treatment options and predicting a person's prognosis outlook. There are actually two types of stages for bladder cancer. 1. The clinical stage is the doctor's best estimate of the extent of the cancer, based on the results of physical exams, cystoscopy, biopsies, and any imaging tests that are done such as CT scans. 2. If surgery is done, the pathologic stage can be determined using the same factors as the clinical stage, plus what is found during surgery to remove the bladder and nearby lymph nodes. AJCCT&M staging system for bladder cancer. The staging system is a standard way for members of the cancer care team to describe the extent of cancer spread. The staging system most often used for bladder cancer is that of the American Joint Committee on Cancer (AJCC). This is also called the T&M system. The T&M staging system is based on 3 key pieces of information. 1. T describes how far the main primary tumor has grown through the bladder wall and whether it has grown into nearby tissues. 2. M: indicates any cancer spread to lymph nodes near the bladder. 3. M: indicates whether or not the cancer has spread metastasized to distant sites, such as other organs or lymph nodes that are not near the bladder. T categories for bladder cancer. The T category describes the main tumor. T-Dex, main tumor cannot be assessed due to lack of information. T0, no evidence of a primary tumor. TAW, non-invasive papillary carcinoma. TIS, non-invasive flat carcinoma in situ, or CIS. D1, the tumor has grown from the layer of cells lining the bladder into the connective tissue below. It has not grown into the muscle layer of the bladder. D2, the tumor has grown into the muscle layer. T2A, the tumor has grown only into the inner half of the muscle layer. T2B, the tumor has grown into the outer half of the muscle layer. D3, the tumor has grown through the muscle layer of the bladder and into the fatty tissue layer that surrounds it. D3A, the spread to fatty tissue can only be seen by using a microscope. D3B, the spread to fatty tissue is large enough to be seen on imaging tests or to be seen or felt by the surgeon. T4, the tumor has spread beyond the fatty tissue and into nearby organs or structures. It may be growing into any of the following: the stroma, main tissue of the prostate, the seminal vesicles, uterus, vagina, pelvic wall, or abdominal wall. T4A. The tumor has spread to the stroma of the prostate in men or to the uterus and/or vagina in women. T4B. The tumor has spread to the pelvic wall or the abdominal wall. Bladder cancer can sometimes affect many areas of the bladder at the same time. If more than one tumor is found, the letter M is added to the appropriate T category. Then categories for bladder cancer. The N category describes spread only to the lymph nodes near the bladder in the true pelvis and those along the blood vessel called the common iliac artery. These lymph nodes are called regional lymph nodes. Any other lymph nodes are considered distant lymph nodes. Spread to distant nodes is considered metastasis, described in the M category. Surgery is usually needed to find cancer spread to lymph nodes, since it is not often seen on imaging tests. Index. Regional lymph nodes cannot be assessed due to lack of information. M0. There is no regional lymph node spread. N1. The cancer has spread to a single lymph node in the true pelvis. N2. The cancer has spread to 2 or more lymph nodes in the true pelvis. N3. The cancer has spread to lymph nodes along the common iliac artery. M categories for bladder cancer. M0. There are no signs of distant spread. M1. The cancer has spread to distant parts of the body. The most common sites are distant lymph nodes, the bones, the lungs, and the liver. Stages of bladder cancer. Once the T, N, and M categories have been determined, this information is combined to find the overall cancer stage. Bladder cancer stages are defined using 0 and the Roman numerals I to IV 1 to 4. Stage 0 is the earliest stage, while stage IV is the most advanced. Stage 0A to M0, M0. The cancer is a non-invasive papillary carcinoma. It has grown toward the hollow center of the bladder but has not grown into the connective tissue or muscle of the bladder wall. It has not spread to lymph nodes N0 or distant sites M0. Stage 0 is TIS, M0, M0. The cancer is a flat, non-invasive carcinoma. It is also known as flat carcinoma in situ. The cancer is growing in the inner lining layer of the bladder only. It has neither grown inward toward the hollow part of the bladder nor has it invaded the connective tissue or muscle of the bladder wall. It has not spread to lymph nodes N0 or distant sites M0. Stage IV1, M0, M0. The cancer has grown into the layer of connective tissue under a lining layer of the bladder but has not reached the layer of muscle in the bladder wall D1. The cancer has not spread to lymph nodes N0 or to distant sites M0. Stage IIT2A or T2B, M0, M0. The cancer has grown into the thick muscle layer of the bladder wall, but it has not passed completely through the muscle to reach the layer of fatty tissue that surrounds the bladder D2. The cancer has not spread to lymph nodes N0 or to distant sites M0. Stage IIT3A, D3B, 44A, M0, M0. The cancer has grown into the layer of fatty tissue that surrounds the bladder D3A or D3B. It might have spread into the prostate, uterus, or vagina, but it is not growing into the pelvic or abdominal wall D4A. The cancer has not spread to lymph nodes N0 or to distant sites M0. Stage IV. One of the following applies. T4B, M0, M0. The cancer has grown through the bladder wall and into the pelvic or abdominal wall T4B. The cancer has not spread to lymph nodes N0 or to distant sites M0. Or NET, N1 to N3, M0. The cancer has spread to nearby lymph nodes N1 N3 but not to distant sites M0. Or NET, NEN, M1. The cancer has spread to distant lymph nodes or to sites such as the bones, liver, or lungs M1. What is bladder cancer rating? Rating of bladder cancer is done by the pathologist by examination of the tumor specimen under a microscope. It is a measure of the extent by which the tumor cells differ in their appearance from normal bladder cells. The greater the distortion of appearance, the higher the grade assigned. High-grade cancers are more aggressive than low-grade ones and have a greater propensity to invade into the bladder wall and spread to other parts of the body. An example of grading is listed as follows. 1 Grade 1, cancers have cells that look very much like normal cells. They are called low-grade or well-differentiated and tend to grow slowly and are not likely to spread. 2 Grade 2 cancers have cells that look more abnormal. They are called medium-grade or moderately differentiated and may grow or spread more quickly than low-grade. 3 Grade 3 cancers have cells that look very abnormal. They are called high-grade or poorly differentiated and are more quickly growing and more likely to spread. Depending upon which cancer organization your clinician follows, the grades above may differ slightly. In general, they all follow the same pattern. Bladder cancers with a higher number 0 through 4 are considered more aggressive and more difficult to treat. In 2004, the World Health Organization developed a new grading system for bladder cancer. This system divides bladder cancers into the following groups. 1. Urothelial papilloma, non-cancerous benign tumor. 2. Papillary urothelial neoplasm of low malignant potential PUNLMP, slow-growing and unlikely to spread. Some clinicians lump urothelial papillomas and PUNLMP neoplasms together. 3. Low-grade papillary urothelial carcinoma, slow-growing and unlikely to spread. For high-grade papillary urothelial carcinoma, more quickly growing and more likely to spread. However, the World Health Organization has recommended changing bladder grading to only 2 categories. 1. The first category being well differentiated or low grade. 2. The second category being poorly differentiated or high grade. What is transurethral surgery (TURBT) for bladder cancer? The initial surgical procedure that a patient undergoes after the diagnosis of bladder cancer is established is usually a transurethral resection of bladder tumor or TURBT. It is done with the help of special instruments attached to a cystoscope and involves cutting out the tumor and removing it from the bladder with the help of an electrical cautery device. This surgery is done through the normal urinary passage and does not involve an external cut on the body. It is the initial treatment of bladder cancer as well as a staging procedure, since the specimen retrieved from the surgery is sent to a pathologist who gives his inference on the depth of invasion of the tumor in the bladder wall T stage as well as the grade high/low. Further treatment depends to a large extent on the findings of this initial surgery as well as the other staging investigations and is covered in the sections to follow. TURBT is the most common treatment for bladder cancer. What is the treatment for superficial bladder cancer? Superficial bladder cancer is a cancer which has not invaded the muscle wall of the bladder and is confined to the inner lining of the bladder. The T stage is top, D1, or it is also known as carcinoma in situ or CIS. 1. After the initial TURBT or biopsy in case of CIS, the subsequent treatment in these cases may involve A. Observation with regular follow-up with cystoscopy examinations of the bladder. B. Installation of medications in the bladder, or in certain cases, surgical removal of the bladder radical cystectomy. 1. Small low-grade, superficial bladder cancers may not require aggressive management after the initial TURBT and may be simply followed up by doing repeated cystoscopy examinations at regular intervals, usually every 3 months for the initial 2 years and then at increasing intervals. 2. Recurrent tumors may be surgically removed or fulgurated burnt out with special instruments passed through the cystoscope. It is very important to note that 30 to 40% of these tumors tend to recur and these recurrences may not be associated with any symptoms. 3. Single dose of a chemotherapy medication, for example, mitomycin fumitomycin put inside the bladder immediately after the TURBT can decrease the chances of recurrence within the first 2 years after surgery. For high-grade, larger, multiple, or recurrent superficial bladder cancers may require additional treatment after the initial TURBT. A. The Bacillus-Calmette-Guerin, commonly referred to as BCG. It is a modified form of a bacterium that causes tuberculosis in cattle, Mycobacterium bovis. It is instilled into the bladder in the form of a solution using a catheter placed in the urinary passage. It acts by stimulating the immune system of the body to act against the cancerous bladder cells and prevent their growth and development. It has been shown to decrease the chances of recurrence of bladder cancer as well as its invasion into the muscle layer of the bladder. However, it is only partially effective in achieving these objectives, and its use does not obviate the need for a regular follow-up. ****It is usually administered in 6 initial doses at weekly intervals followed by a maintenance schedule that is usually recommended for at least once per year but may be needed for as long as 3 years. The patients who do not respond to BCG treatment have recurrent bladder cancer in spite of treatment. For those who have medical issues which preclude the use of BCG may require other forms of treatment. These include 1. Bladder instillation of immunotherapy agents such as interferon or chemotherapy medicines like valrubicin, vulstarmitamycin C, epirubicin L and doxorubicin adriamycin. In general, these medications are not as effective as BCG and help only a small minority of patients who have not responded to BCG. 2. In patients who have an aggressive form of high-grade superficial bladder cancer and those who have not responded or who have recurrent bladder cancer in spite of treatments mentioned above, the more aggressive form of treatment may be warranted. This is usually in the form of a major surgical procedure called radical cystectomy. It entails removal of the bladder and the prostate and diverting the urinary stream using parts of the intestine. What is surveillance for superficial bladder cancer? Patients diagnosed and treated for superficial bladder cancer need regular follow-up to detect recurrences and treat them effectively. The following is a typical follow-up protocol. 1. Cystoscopy and urine cytology every 3 months for 2 years, every 6 months for the next 2 to 3 years, and annually thereafter. 2. Imaging study CT scan/intravenous urogram of the kidneys and ureters once every year, especially for high-grade tumors/those associated with cysts. 3. Cystoscopy and cytology detect recurrence in the bladder itself while cord/IDU is used to detect a tumor in the kidneys and ureters. 4. Patients with bladder cancer are more likely to get upper urinary tract, kidney and ureter tumors that arise from the inner lining of these organs and share a common origin with bladder tumors. 5. The risk of upper urinary tract recurrence depends on the stage and grade of the initial disease and the response of the tumor to BCG. 6. Individuals with recurrent high-grade bladder tumors can have a risk of developing a tumor in the upper tracts and need to be followed closely in this regard. 7. Commercially available tumor markers that are used to test urine samples for evidence of bladder tumor recurrence are also being used in follow-up protocols. However, their exact role is undefined as of now, and they are not considered an adequate substitute for cystoscopy and cytology. Some of these tests and markers are NMP22, BTA STAT, BTA TRAC, and UROFICN. What is the treatment for muscle-invasive bladder cancer? 1. Radical cystectomy done for muscle-invasive bladder cancer. The procedure entails removal of 1. The bladder, 2. prostate, 3. seminal vesicles, 4. the fatty tissue around the bladder, 5. lymph nodes in the pelvis on both sides of the bladder through an incision made in the abdomen or laparoscopy. It has been shown that patients who undergo a thorough lymph node dissection have a better chance of cure as compared to patients who either do not receive one or undergo a less extensive dissection. The use of laparoscopic approaches significantly decreases blood loss during the surgery, and may help in early recovery by decreasing post-operative pain at the surgical site. An additional advantage of the ROBA is that it permits an enhanced magnification of the surgical field with three-dimensional vision, which helps to enhance surgical precision. Once the bladder has been removed, the urine needs to be diverted. There are 3 popular ways of doing that. All of them require the use of segments of the intestine that are still connected to their blood supply but have been disconnected from the gastrointestinal tract. 1. Ileal conduit (incontinent diversion) is the most extensively used form of urinary diversion. It is also the simplest and the least time-consuming form of diversion and has the least chances of complications in the short and long term. This entails the use of an intestinal segment, one end of which is connected inside the body to the ureters that drain urine into it from the kidneys, while the other end is brought out to the level of the skin and is covered by an external appliance, the urestomy bag. The urine from the kidneys continuously drains into the bag through ureters and the ileal conduit. The bag can be emptied at regular intervals or when it is nearly full by opening a tap-like attachment at the lower end of the bag. The major advantage of this procedure is that it is relatively straightforward to perform with the least chances of complications. The disadvantages include the need to wear a bag all the time and the resultant negative impact that may occur on body image. 2. Orthotopic neobladder entails the creation of a new bladder neobladder with the help of an intestinal segment and connecting it to the natural urinary passage so that a person may be able to pass urine more normally. The advantage of this procedure is that it avoids the need to wear a bag, and the patient can pass urine in a more natural fashion. The disadvantages: 1. Difficult procedure. 2. Longer recovery period and may 3. Short-term and long-term complications. including a persistent urinary leakage (BINABILIDY) to pass urine requiring the use of self-intermittent catheterization. 3. Continent catheterizable pouch. For example, Indiana pouch: continent diversion is a form of milk bladder which is not connected to the normal urinary passage but instead has an opening or a stoma at the level of the skin on the abdomen through which a catheter can be passed to empty it periodically. This has a valve-like mechanism that prevents the leakage of urine through this opening, thereby precluding the need to wear a bag. It is used at patients desirous of and fit for a continent urinary system while being unsuitable for an orthotopic milk bladder due to certain circumstances such as cancer at the point where the bladder joins the ureter. Certain patients, however, may be unfit or unwilling to undergo this surgery. These patients can often undergo a combination of extensive TURBT, chemotherapy, and radiation in an attempt to cure or control the disease without the need to remove the urinary bladder surgically. Radiation to the bladder can, however, lead to its own set of problems and complications, including radiation damage to the bladder and rectum which give rise to bleeding and irritative symptoms, radiation cystitis and radiation proctitis. What is chemotherapy for bladder cancer? Patients who are diagnosed with metastatic bladder cancer M-stage, M1, cancer which has spread to other parts of the body are usually treated with chemotherapy. 1. Adjuvant chemotherapy. Chemotherapy may also be used in cases of locally advanced bladder cancer T-stage, B3 and above and/or N-stage, N1 and above in an attempt to decrease the chances of the cancer coming back after radical cystectomy. 2. Neoadjuvant chemotherapy. By giving these medications before radical cystectomy in an attempt to improve the results of surgery and decrease the size of the tumor before the operation. Chemotherapy has the potential to control metastatic bladder cancer and increase the chances of cure when used in a neoadjuvant or adjuvant setting along with surgery. However, chemotherapy has its own set of side effects and may not be tolerated by all individuals. The time-honored chemotherapy regimen for bladder cancer is called the MVAC. It is a combination of 4 medications given in cyclical form. M.KHATER, Rumetrax, Trexol V, vinblastine A, doxorubicin, adriamycin C, cisplatin, platinol AQ. Oncologists currently prescribe MVAC in 8-dose dense fashion. This means the patient takes the drugs more frequently than was previously done in the accepted treatment schedule, as well as taking growth factors to help the blood counts to recover faster from the effects of the chemotherapy drugs. Some patients with heart disease may not be in a condition to receive adriamycin and may receive CMV instead. CMV equals MVAC without adriamycin. An alternative regimen is a combination of gemcitabine, Gemzar, and cisplatin. This is increasingly being used nowadays since some studies have shown that it is equally effective as the MVAC regime with fewer side effects. However, about 40 to 50% of patients have medical issues that preclude the use of this therapy. Cisplatin, which is the main medication in all these regimens, cannot be given to patients who have an abnormal kidney function. In this case, it may be substituted by carboplatin paraplatin, which, however, is not as effective as cisplatin-based chemotherapy. Carboplatin-containing regimens are not recommended in place of those containing cisplatin to render the drug cocktail more effective. The following is a list of compounds that are used by some clinicians to treat various stages of bladder cancer, usually in combination with other anti-cancer cell compounds. Fluorouracil 5-food gemcitabine ematrax vinblastine valrubicin carboplatin efasimide thioethidacetaxel. External radiation. The few cancer treatment centers use, in addition to chemotherapy and endoscopic resection, external radiation beam therapy to treat patients. However, the protocol is considered complex with toxicity and high pre-treatment mortality death rates mainly due to sepsis from the chemotherapy. External beam radiation therapy is mainly used in other countries. It is infrequently used in the United States. What is the prognosis for bladder cancer? The most important factors that impact the prognosis of bladder cancer are 1. Stage 2, grade of the tumor. The lower the stage and grade, the better the outlook. 3. Other factors such as number, size, pattern of recurrence if any. 4. Response to initial treatment like BCG, coexistent carcinoma in situ, and certain genetic mutations also play a role. The table below is based on the National Cancer Institute's database. Stage relative 5-year survival rate source, National Cancer Institute SEER database 0, 98% I, 88% II, 63% III, 46% IV, 15% ** for low-risk superficial bladder cancer top. Low grade. The chances of recurrence are about 50% in 5 years after the initial diagnosis. This necessitates regular follow-up, even in these low-risk tumors. However, unlike the more aggressive variants of bladder cancer, the chances of progression, for example, chances of the tumor invading into the deeper layers of the bladder, are minimal. Typically, these tumors, even when they recur, do so in the same stage and grade as the original tumor and do not compromise the life expectancy of the patient. High-risk superficial tumors are those that are high-grade, B1 tumors, and are associated with extensive areas of carcinoma in situ. Multiple tumors, large tumors, and those that recur despite BCG treatment are also at an increased risk for recurrence and progression. These tumors have a recurrence rate in a range of 50 to 70% at 1 and 5 years, respectively. They are also much likely to invade into the deeper layers. These tumors need to be managed and followed up more aggressively since they have a potential to invade and spread to other parts of the body, thereby shortening the life expectancy of the patient. After radical cystectomy, survival depends mostly on the stage of the disease. The 5-year disease-specific survival for various stages after the radical cystectomy is as follows. D2, M0, 70 to 80% D3, M0, 40 to 50% T4, M0, 25 to 30% N+, patients with lymph node involvement. 15 to 20% continued reading. Can bladder cancer be prevented? The best way to prevent bladder cancer is to avoid exposure to agents that cause the disease. 1. People who don't smoke are 3 to 4 times less likely to get bladder cancer as compared to smokers. Continuing to smoke after the diagnosis of bladder cancer portends a poorer outcome and increases the chance of the disease coming back after treatment. 2. Avoidance of occupational exposure to cancer-causing chemicals such as aniline dyes may also be important. Despite research in this area, no medication or dietary supplement has been conclusively demonstrated to decrease the risk of bladder cancer in normal individuals. However, recent studies of patients taking atorvastatin Lipitor to lower cholesterol have suggested the drug may lower the risk of prostatic cancer and by inference, bladder cancer, but this needs further study.
بكده نكون انهينا المحاضرة بتاعة اليورينري بلادر كانسرز. أتمنى إنها تكون مفيدة، أتمنى إنها تكون نالت إعجابكم. لا نسألكم إلا دعاء. اشترك في القناة، انشر الفيديو. نسأل الله عز وجل أن يجعل شفاء الناس بأيدينا وأيديكم، والسلام عليكم ورحمة الله وبركاته.